Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. All right. Well, I am really excited to be here today with Kaley Mounce. She is a friend and also a coworker. She's one of the nurse practitioners that works in our group. And I'm really excited to talk to her today about seizures. We're going to try to keep this simple because this is something we see in the ER a ton. It's something we see on a daily basis. It's something that I think ER providers don't love taking care of in general, but it can be made a lot more simple if you're more comfortable with the ideas and have an idea of what neuro would like to hear from us. And that's kind of the goal of this podcast today. We're going to talk a little bit about febrile seizures. So, Kaley, welcome. Thank you for joining me.
Hi, thanks for having me.
I think it's so ironic that you and I are sitting here across the table talking about seizures today because I have known Kaley for more than 20 years. She was actually my babysitter when my 22-year-old son was a baby. And lo and behold, he had a febrile seizure under the care of Kaley, who was how old at the time?
Oh my gosh, 18, I think.
My mind said 17.
Yeah, maybe. I don't know. It's been a long time.
And I worked.
Absolutely terrifying. That's what I remember.
I was working at the children's ER. She called me and I was like, it'll be okay. Like, you obviously had a very different experience.
Yeah, no, that was not how I felt about it. I was like, he's shaking. I don't know what's going on. Had no medical experience. I was freaking out.
Yeah. Well, now we're both advanced practice providers and we're working together in the children's ER, which is really cool. A little full circle experience of us knowing each other. But the reason why Kaley's here today is because you worked with neuro, right?
About 2.5, almost 3 years.
Okay. With our peds neuro group here in Chattanooga, which is awesome. And so I'm glad you're here to talk to us today. What is a febrile seizure?
So the way I once heard Dr. Febrile describe it and how I feel like it's best understood is it's an immature nervous system. So very much like the little one's emotions, they just kind of overreact. And in the setting of illness, they're supposed to develop a fever to help fight off that infection, but their immature nervous system makes it spike very high or very quickly, and that causes a misfire of the neurons, causing them to have seizure.
Okay. So we like to divide these into two categories, simple and complex. Tell me what simple is.
Simple is typically a generalized convulsive episode. It's going to be lasting less than 15 minutes, only one occurring in the 24-hour period, and they're fairly quickly back to baseline.
Okay. Typically, what age group are we seeing this in?
So anywhere from 6 months to 5 years. Usually the first febrile seizure is going to happen around 12 to 18 months, though.
Yeah. And what does a typical febrile seizure look like when we talk about like describing a seizure?
Mm-hmm. So generalized convulsions, sometimes the eyes will roll back. They may have kind of gurgling or gasping type noises. Again, should be lasting less than 15 minutes, and they'll have some postictal period, should be about 5 minutes or so, and then start arousing thereafter.
Okay. We see tons of this in the ER all the time. I think even in a community ED, you're going to see this a lot. So what is our approach when we assess this child and we do our physical exam and we talk to the parents? What kind of information are we trying to elicit from them, and what are we looking at when we touch this patient?
So have they been sick? Did the parents have any kind of indication that they were sick prior to this? With simple febrile seizures, a lot of times this is the first symptom that they are aware that they're sick. When we get them to the ER and determine or just figure out that they have a fever. And then, a lot of good history can help you figure out, is this truly just a simple febrile seizure, or is this going to lead us down another pathway? Do they have developmental delay? Is there a significant family history of epilepsy versus just febrile seizure? Do they have an injury or ingestion or anything like that? History is key.
Yeah, certainly. If they have a VP shunt, we're going to be on a totally different pathway.
Absolutely.
For sure. So collecting a good history. When you talk to parents about the seizure, what kind of information are we trying to collect? Like duration or what it looked like, or what all are you asking them to describe?
Absolutely. So most of them are terrified when they come in, especially if this is the first time they've ever done this. So getting them to recall this information can be really hard. They will give you very vague description of, I don't know, they were shaking everywhere. So trying to help them to, number one, calm down and reassure them, but walking them through it. What were the eyes doing? What was the mouth doing? Did they change colors? Were they breathing? Were they gasping? What were their arms doing, their legs doing, and so forth? And that'll kind of get you a little bit better description. And sometimes I will find that maybe this was not even wasn't a seizure. We're looking at something totally different when they came in with chief complaint of seizure.
Yeah, I love that description, just kind of walking through the whole body system, because they're frantic and they're scared to death. And oftentimes we're just kind of petting them to help them to realize, okay, it's going to be okay. And we're going to look at your kid. So then we do a physical exam. And what are we looking for?
Signs and symptoms of what caused the fever.
Right.
Really. I mean, with a simple febrile seizure, you're just going to be treating that illness and trying to figure out what that was that prompted this.
Yeah. And I tell parents, really my job here, we know these seizures are relatively benign. I'm looking at your kid and trying to figure out why they have a fever today. Do I see a bacterial focus on exam that's going to kind of dictate our care today?
Yeah.
What about their description of like their mental status?
Again, so they should be kind of perking up and returning back to baseline by the time they get to us. If they are not, then I'm worried that something more may be going on and again, lead us down a different pathway.
Okay, great. So what labs, imaging, LP, what are we thinking about when we look at a kid with what we think is a simple febrile seizure?
Keep it simple, stupid.
Yep.
Don't do that much. If this is, characteristic-wise and definition-wise lining up with a simple febrile seizure, you just need to find your source of illness, or if it's viral, treat it accordingly.
Yeah. So literature shows there's a very little correlation with a serious bacterial infection in children that have one simple febrile seizure.
Most typically is viral.
Exactly. And so there's no true workup indicated here unless you see something specific in the history or physical exam that makes you think about a different pathway to go here. So great. I love that. So really we can feel very comfortable if somebody fits into this category, really doing nothing except doing a lot of hand-holding with the parents. Even though my experience with a febrile seizure was actually pretty minimal, I actually tell them, my kid had a febrile seizure. It's a really scary experience. So I know what you're feeling right now, but let me tell you what we're going to do today. And it oftentimes will kind of calm them down because they know that we know that this is scary for them to experience.
And I think just reiterating that, all the data shows that these kids with simple febrile seizures, they don't have brain injuries. They don't go on to develop developmental delays or anything. It is just limited to that age group, and they don't have any lasting effects.
Okay. So let's talk a little bit about the scripting for parents. I mean, I think this is where everybody struggles the most, right? We have to convince this anxious parent that it's okay and that they can take this child home. I get a lot of questions like, do I have to stay up and watch my kid all night? What if he has a seizure while he's sleeping? What do I need to give Tylenol every single time he has a fever? All these really scared and concerned questions. What would your guidance be? What do you tell them?
So a lot of what we've already been over, I talked to them about what's caused this febrile seizure, how we're going to address that. We're going to treat the illness. They are at a slightly higher chance of having a reoccurrence of febrile seizure, but it's okay. And I give them the worrisome symptoms and signs to look for going on the complex febrile seizure pathway, but just reassurance. And then talking to them again about, the low risk of anything long-term happening because of this. It's not causing brain damage as they once used to think.
So I'm a parent. Tell me what you're going to tell me.
I get it. I know you're stressed out. I've been there. I've done this. Like the first febrile seizure I ever witnessed was a little boy that I was babysitting, and it was absolutely terrifying. I understand what you're going through, and that wasn't even my own kid. So first and foremost, look at them now. They look great. They're doing good. Their physical exam's reassuring. We talk about the cause of febrile seizure, how we're going to treat this. And then, we don't need to follow up with neurology. We don't need anti-epileptics. This may or may not ever happen again in the setting of illness, but as long as it's fitting into this category, we're not worried about it causing lasting effects.
Okay, awesome. Thank you. All right, so now what? What's our disposition? What do we do with this patient?
Send him home.
Yeah.
Yeah.
All right. I know.
Treat accordingly.
Seems crazy.
Tylenol, ibuprofen, which is not going to help prevent future febrile seizures, but treat their symptoms, help them feel better.
Yeah. I'd specifically talk to parents about not fever chasing in the future. You can drive yourself crazy, treating every single little fever that your kid ever has because they might have another febrile seizure. You are going to just make yourself nuts. There's nothing you can do to predict this or not. Rest assured that if it happens again, we're here and you're going to bring your kid back. Do you tell them to call 911 or come back if they have another seizure?
If it's lasting more than 5 minutes, then yes. If it's simple febrile seizure, is real quick, by the time they can even get to the phone, it's done and over with, and the kid's starting to wake up, no, you do not have to call us for that. You can talk to your pediatrician, let them know it's happened again so they can kind of keep an eye on it. If it's happening more frequently, may need a referral. But if it's real fast, they don't have to come back.
Okay. What about following up with neurology? I think we talked about this.
So for simple febrile seizures, no, they don't need a neurology follow-up.
Perfect. All right. On to complex febrile seizures. What is that?
Complex is quite the opposite of simple. Okay. So can be focal and presentation lasting more than 15 minutes, occurring more than one time in a 24-hour period, or having a prolonged or altered postictal phase.
So when we're assessing our complex seizures, what changes here? What are we looking at for physical exam findings?
Do we have any neurologic deficits? I always want to check my DTRs. Do we have hyperreflexive DTRs? Do we have clonus? Am I concerned that they may have another seizure? Fairly quickly, I'm going to be a lot more aware, putting them on monitor, close seizure precautions.
Yeah. What would you order for this patient?
Monitoring and, if they've already stopped seizing, then just your general workup like you would do for a simple febrile seizure, trying to figure out the cause of it. But the issue here is, are they going to go into status, or are they going to have ongoing seizures during that episode?
So typically you'd order CBC?
I don't.
Okay.
No, it's typically going to be viral. If there's something certainly indicating it on your physical exam, then you may want to do that, but not just because they had a complex febrile seizure.
Electrolytes, blood glucose?
Yeah, sure.
Yeah, I typically do that. Are we looking at like inflammatory markers?
You can, again, just depending on the cause. If this is a kid who's had complex febrile seizures in the past, and we know this goes along with their illnesses, then fine. But certainly with complex, we start expanding our differential, like you mentioned, do we have electrolyte imbalance? Is that our blood sugar? Kind of reaching for more things because it's not just simple.
Okay. So for like a new ED provider that's starting, maybe doesn't see this very often, and they're not super comfortable managing this, what would be like just the basics that you would order to get started on a patient like this?
And if they've never had a complex febrile seizure, this is not part of their history, probably, like you said, just CBC, CMP, CRP, depending on the age, maybe a procalcitonin, blood sugar monitoring.
Okay.
Yeah.
What about urine? Oh, yeah,
UTI.
yeah. Looking for any kind of infection?
Yeah, just broad looking for infection.
Okay. What about neuroimaging?
Yeah, so if they're not to baseline, if they're having a very prolonged postictal phase, or you're getting focal deficits on exam, or asymmetric DTRs or anything, absolutely consider neuroimaging.
Okay.
In general, for seizures, MRI is going to be the better imaging, but we're not going to get that from an ER standpoint. So if you need to and you feel it's more urgent than a CT, non-contrast, and then they can finish the workup while inpatient.
Okay. What about an LP?
So if you think about that, make sure you get your neuroimaging first. You don't want to bring mass or an abscess and then drain that and have some compression. That could be bad. So
yeah, good thought process. And I was just reading a lot, like if you're thinking that this is meningitic, typically that's going to present with something else, right?
It's symptoms. Yeah.
Yeah, it's not going to just always be a seizure. They're going to look meningitic.
Whatever.
Yeah. Some petechial rash, nuchal rigidity. Yeah.
Right.
That altered mental status, I think, is one that we rely on a lot with meningitis.
And again, probably not going to be the first symptom that we've been sick. We've probably been sick for a while at that point, if it's now led to seizures.
Sure. Do these kids need an EEG?
So there's some debate on that. In the midst of their fever and illness, they can have some abnormal discharges, but it doesn't necessarily mean that they have epilepsy. So most neurology or neurologists are going to want a EEG about 2 weeks after the illness. But certainly, if we're concerned that are they having status, we're still not back to baseline, what's going on? Absolutely get an EEG if there's a more emergent need for figuring that out.
Yeah. Let's talk a little bit about how you can have a seizure with a period of altered mental status followed by another seizure, but that's really considered one episode if you don't recover.
Yes, absolutely. And then starts raising my concern for status.
Yeah.
If we're not returning back to baseline, then that's definition of status.
Yeah. So clustering without that good return to that normal neurologic baseline is considered all a seizure. All right. The disposition of complex febrile seizures, what do we typically do?
Typically admit.
Yeah.
Yeah. Even if they've had complex febrile seizures before, because like we said before, the risk is that they're going to have another one or they're high risk for status. And they need to be in the right place at the right time, especially during that acute illness.
Okay, great. And on an inpatient, since I haven't worked in inpatient peds, does neuro typically get consulted the next day on these complex febrile seizures?
Yeah.
Okay. So they do come in and give any potential recommendations if they think this is maybe an underlying epilepsy or something else. Okay, great. All right, let's talk about febrile status epilepticus. It's not something we see a ton of, but certainly can happen anytime we're talking about seizures. What does that mean?
Seizures lasting more than 15 minutes. A lot of times by the time they've gotten to us, EMS has already tried a dose of medicine or two. If it's requiring abortive therapies, then it's going to meet a status definition.
Okay.
Or like you mentioned, not returning to baseline before we go into another one.
So when we get a kid that we're concerned has status, our first approach is going to be?
Airway management.
Airway management, yeah. And then we move into medications. You mentioned we're going to use
some benzos.
Yeah. Usually a couple rounds of benzos.
Right.
And then we're talking about moving on to something else.
Right. Start considering one of our other meds, Capra, phosphatidylcholine, arbitol, Depakote.
Okay. And I'll attach on the notes here just some dosing guidelines for benzodiazepines in children. But these are critical care patients. And so when you have a kid like this in our department anyway, we are very fortunate to have fantastic attendings who help us with these more complex patients. That may not be the case if you are working in a rural center and perhaps you're the only APP on duty and you're taking care of the patient. So knowing that it's important to manage their airway early and what your meds are going to be working through this would be important to know. So we have the benefit of working at a children's facility. So we have a lot of resources available, but it'd be really good to have something like this with the dosages and things that you can use in your pocket for when this does happen. All right. So great. That was awesome. Let's talk a little bit more about things that can kind of look like seizures and kind of opening up your differential. Like what else do we need to think about when we're assessing these patients? What else could this be?
So when it comes to febrile seizure, I mean, we've kind of hit on most of this, but if they come in with fever and they're having a seizure, there's no history of non-provoked seizures, you're not worried about meningitis or anything like that, then we can pretty quickly classify this, unless you're seeing something else focal on anxiety.
Sure. What about breath holding spells?
Yeah. We have lots of kids with breath holding spells. Usually it's triggered by high emotion, not usually associated with fever. And so trying to, again, getting a good history from the parents, getting a good description of what was happening before these events, what did the event look like, how long did it last, and so forth can help you kind of clarify that. And then having parents video these things is so helpful. No matter if you think it's a breath holding spell, a reflex spell, anything, like have them video if it's happened multiple times. And that can help you kind of put to words what it actually looked like. Because again, they're stressed. They don't remember what it looked like. They're just panicking.
Yeah, it's great. What about shaking? My kid's shaking. I don't know what it is. How do
In the setting of fever?
Yeah.
Yeah, sometimes that can be hard to determine, was this seizure or was this just chills? So level of consciousness is a huge one, and again, walking them through that. What were their eyes doing? Did their eyes roll back? Were they closed? Were they open? Was their mouth moving? Were they gasping for air or whatnot? I mean, if we've got eyes rolling back and we're gasping for air and we're shaking all over, I don't think that's chills.
Right.
Doesn't sound like chills.
Right. But if
We're wide awake and we're shivering all over and we're still whining because we don't feel good, that's chills.
Exactly. Yeah, I like that. Okay, so let's talk a little bit about charting, like some tips on how we can document this a little better for somebody that maybe isn't accustomed to talking about neurologic complaints. What would your suggestions be on how to chart sort of clearly on this patient?
Mm-hmm. So again, if you can break down the characteristics of the seizure and chart that helps future people be able to determine was this truly febrile or not, and especially if your differential is broadening later on or if this was complex, and it can help you differentiate that. And then back to history. Again, family history is important. If we have a strong family history of epilepsy, but no febrile seizures, then I might start thinking, okay, this could be potentially a seizure that's just had a lowered seizure threshold because of the illness, whether it's first time or not, and may push me more towards anti-epileptics faster than just a typical febrile seizure that's full.
Yeah. I've had neuro ask a lot about eyes. I've started describing what children's eyes do. I've had the neurologist ask me that on the phone. So I've started kind of giving real specific descriptions in my charting that I probably didn't do before. So thought that was a helpful tip from neuro.
Yeah, that's a great point, because a lot of times if they have like a new focal point that it's originating from, they will look towards it. So if your eyes are constantly going up or left, okay, that's a little more indicative that we may have something else going on.
I didn't even know why they were asking me that question, but that's awesome. All right. And then I also just reading, it's a great idea when we're talking about differentiating these kids on your charts to make very clear in your charting that this kid did not look meningitic. So writing that they had full range of motion of their neck and they don't look meningitic, there's no rash, a great thing to do. And then documenting the parents reported them being at baseline is something that we here at Children's do all the time.
Yeah.
So, their parents know their kid the best. So it's always good to document that they can do that and then they can PO successfully before we send them out the door. All right. So let's say we have a case that's a little bit more complex. We're going to admit this kid and we feel like we need to call the neurologist. Tell me what a neurologist is going to want to hear from me when I call. So I'm prepared to give them the information they're going to need.
So some of the characteristics, how long it lasted, how long their postictal phase was, and I'm assuming if you're calling them, it's because it was complex. They don't want to know about your simple febrile seizures. And your complex, I mean, really, you can admit them and they can consult neurology in the morning. There's not really a question that you have for them overnight. If it's somebody that they're going to start on anti-epileptics, it's, again, not getting started right now. We're going to treat, if it's status, we're going to treat status and do our thing. So most of the time with febrile seizures, there's not going to be anything that you need to call the neurologist for that night.
Okay, great advice. All right, got any interesting cases to tell us about?
Just a little personal one. When I was a nurse and in the ER, I took care of a little one who started having febrile seizures. I think he was right around the age of 6 months. So, febrile seizures can happen between 6 months to 5 years. But if it starts at the lower end of that range or the higher end of that range, you have more chance of going on to develop epilepsy and further complications. Well, this little boy, he had some delays already, started having febrile seizures at a very young age. And we saw him probably at least once a month in the children's ER. And then actually when I went to become a nurse practitioner in peds neurology, I took him on as a patient as well. So followed him for several years up until about the time he was 5 with his complex febrile seizure diagnosis, continuing to show other signs of developmental delay. And then he has now gone on to be diagnosed with epilepsy since then and is on multiple anti-epileptics. And I think they've done some genetic testing on him and found that there's some abnormalities there that gave him a predisposition for epilepsy as well.
That's interesting. I read a little bit about that last night. Are they doing more genetic testing on these kids with seizures?
They do. If they have lots of seizures or other developmental delay or strong family history of seizures, then they will send them to genetics and see if there's something that'll pinpoint why.
Have you ever seen a kid that had a bunch of febrile seizures and then didn't grow up to have epilepsy?
Absolutely.
Okay.
Absolutely. So with simple febrile seizures, happens all the time. The majority of them do not go on to develop epilepsy. Slightly higher chance with complex, and certainly the ones that have numerous complex febrile seizures are going to have higher risk.
Okay. All right. Excellent. Well, I think we covered it all.
Okay.
Thank you for joining me to do this today.
Thank you.
We'll see you next time.
All right. Bye.
Thanks for joining me here today at PEM Chat. I hope you'll join me next month when I'll be speaking with Jennifer Stanfield about non-accidental trauma or child abuse. It's going to be a great podcast, and we're going to talk about how to not miss it, what to do when you find it, and then how to talk to parents about it. I hope to see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.